Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I've got a couple of cases for you and they have one thing in common, which I'll discuss during the course of the procedures. So patient one has got really medially impacted and occluding quite dry earwax, enveloped in dead skin that's still attached to the canal wall. You can see me peeling it away there. So it has semi-shed, if you like, but it's still adherent to the canal wall. And all that white matter you can see is a fungal strain called Aspergillus. Now, there's different types of Aspergillus in the ear. You can get Aspergillus niger, Aspergillus flavus, for example, and they can either present as fungal spores or what you see here, hyphae. So it looks almost like candy floss, cotton wool strands. So I'll give you the case history. This patient first developed blocked left or bilaterally blocked ears back last year, March 2023. They have got a history of swimmer's ear, so whenever they get water in the ear, they develop an ear infection, and so they went to a high street company to have this removed using microsuction. They managed to do their right ear but not this left ear, so they went back on a second occasion and they weren't able to do it. And then on the third occasion, there's a little trend here with some of the high street companies that I've come across. The third attempt, they would recharge you. And so the patient agreed, and although they could hear a bit better after that third attempt, it's still not 100%. And since that, they have got tinnitus in both ears, but in this ear it's been exacerbated because of the wax impaction. They're experiencing occlusion, so they can hear themselves inside their head. Other people were complaining that the patient was speaking too quietly, because when your ears are blocked, what can happen, you can develop what we call autophony. It's when your own voice gets trapped inside your head. You can mimic that right now. You can just, if you get your finger and close the entrance of the ear using the cartilage, which is a triangular piece of cartilage just outside the entrance of your ear, and if you talk, your voice gets trapped inside your head. So other people weren't able to hear this patient speak because because they could hear themselves louder inside their head, they then reduced the overall volume of their voice because they were worried they were speaking too loud. The patient then went to, this is where it got a bit confusing, because they then went to the NHS to have an MRI scan performed because they have got tinnitus worse in this ear. Now, that could have just been because of the wax. I don't think they've seen by ENT. I think it was referred internally by audiology. That came back clear, thankfully. And obviously, this is becoming troublesome for the patient, and they travelled a huge distance to have this removed today. And it was, well, the procedure itself didn't take that long, but it was really impacted, and the skin was quite stubborn. On a couple of occasions, we got a bit of clarinetting, and I did pre-warn the patient because the skin is so adherent and so enveloped around this wax plug, it can squeal a little bit. I weren't able to use any of the instrumentation because it's just too deep in the ear. Obviously, falsets wouldn't have been suitable because it just wasn't the consistency. Resisted to use any drops. Two reasons. First of all, because they have got a bit of a fungal infection. If you use any olive oil drops, the fungi can feed off that, and they can exponentially reproduce and become pathogenic. So, and also when you put drops in, sometimes it can actually make the procedure slightly more noisy because you're suctioning fluid, so it can be a bit more noisy for the patients. And a couple of times the patient did make sudden movements, but they were fine. You can see we managed to remove that plug there. Now, guys, if you wait till the end of the video, I'm also going to upload a diagram I've drawn. I'm busy at the moment in preparation of the launch of our clear wax training courses, or should I say the relaunch. I'm just updating our training material, and I'm on Facebook and Instagram and TikTok. I'm just putting some images of some of the diagrams I'm drawing for the new training material. And I've got, I think, an interesting one for you guys today. It's kind of a bird's eye view of the ear canal. So you're looking down upon it. And I think it'll give you some more perspective about the geometry of the ear, because I think when you're watching it on a video, see it all in its entirety, and you'll just see how bendy and twisted the ear canal is, and how deep it is, and where the wax should be. So it's quite an interesting one. So do stay tuned. I'll add it to the end of the video. So again, the patient, just because it was a bit of clarinetting, we'll just pause. I just asked if they were okay, and they said yes. They just wanted me to peel this away, so I managed to do that. Eardrum's intact. There's a bit of staining there, but that's fine. It's non-significant. I'm just going to mop up near the entrance now. There's a bit of staining in the midsection of the ear canal. Now, I've recommended they use some antifungal solution, which they can get over the counter, fortunately. I've asked them to stop using the olive oil. It seems like this patient has got a susceptibility to developing otitis externa, and if it's a fungal strain like it was today, olive oil was not going to help. So, but they do suffer from extreme itchiness in the ear. You can see some of the skin here is really dry and flaked away. So I've suggested they use an acetic acid spray whenever their ears are itchy. So that obviates the need for then the patient to use a cotton bud, because sometimes they do use a cotton bud. So this is patient 2. So patient 2, I'll give you the case history. Again, they went to this exact same high street company. First time was Unsuccessful. They were told to use drops for, I think, 14 days. And you can see the drops hasn't really done much in this. You see it's still very dry, hard and wax. Very narrow ear, so I suspect the patient struggled to put the drops in, truth be told, and it was just pouring back out. So they went back for the second visit, and on the second visit, the patient had to ask the person to stop. It was just way too painful, and the patient couldn't bear it anymore. And ironically, the person who they saw provided them with my details. So it's very kind of them. So this patient then contacted myself. Straight away upon looking at the ear, I thought it's just not going to really suction very well. It's just got this really dry consistency. I'm just using the new Rye ear hook. It's got a 30-degree angulation bend, and it worked really, really well in this ear because it's such a narrow ear. So I'm just chiseling away small pieces. Patient very happy. Obviously they've been experiencing problems in this ear for about a month now. Also, what I'm going to realise as well, a lot of these companies who, after the second attempt, can't do it, they charge for the third one. Now, if it's a really, really complex case, and you can kind of, if it's extremely complex where even very skilled specialists are going to struggle, then I can understand that, because it's not due to the inability of the specialist to remove the wax, it's just the complexity of the procedure. But as you can see, it didn't take me long to do this. So the third attempt, they are charging now. This is another ethical issue. When you've got unskilled or poorly skilled clinicians removing earwax, and they're not being able to remove it successfully, not because of the complexity of the case, but because of the lack of skill to do it, and then they're charging for sequential attempts. There's an ethical issue there. So this patient, obviously, they were offered a third appointment, but they said no, they're not going to spend any more money there, and so I think they still got charged then at that initial appointment. But also another thing I've noticed is with this particular company, there's two companies actually, after the second attempt, they're advising patients that their wax is not possible to remove using microsuction, so they have to have it irrigated. Now, that's incorrect. I mean, microsuction is the gold standard. It's you're much more likely to remove wax with microsuction compared to irrigation. So I suspect maybe they've been told to say that because they don't want the individuals, obviously in this case they were recommended to see me, but I have a feeling they're told to ask the patient to seek irrigation elsewhere, because if they go somewhere else and have microsuction or a mechanical removal and it's straightforward, then it'll raise questions about the practices, obviously their own practices. So I don't know, I've had a few people mentioned that to me after the second attempt. They were told, oh, this is not going to be removed with microsuction, go and get it irrigated elsewhere, and they don't do it themselves, irrigation. So it's all very peculiar. Anyway, I'll just briefly explain this diagram. So looking at over the top, so it's a bird's eye view of the right ear. You can just see the entrance, that's the widest part of the ear canal, as is the region near the eardrum. Then you've got the first and second bend, so it's quite twisty. You've got all the cilia there, and that's the where wax is secreted and most likely to get impacted. In between that first and second bend, it's called the first isthmus, and you've got the second isthmus narrowing near the eardrum. And then you've got the cartilage portion, the outer third, and then the inner 2/3 of the bone. And you could see that red dotted line, which is a osteocartilaneous junction. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.